Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
So as we start with the management of PCOS, we start with the weight reduction, which is very, very important part. So whenever you start with the management of PCOS, never forget this important element. So usually what happens is when I ask a patient about, ask a student about managing PCOS, they start with, metformin, Inositol, OCPs, maybe going on to ovulation induction, but they miss out on most important counseling, which is on weight reduction. Why do I say that? Listen to this. The mainstay of treatment is lifestyle modification. PCOS is a disease of the urban class. Why? Because sedentary lifestyle, okay? Erratic schedule of eating food. If you go to the village side, all of them eat early, sleep early, get up early. Over here in cities, it's just the other way around. They eat less in the morning, more in the night. Parties are more here. They sleep late, get up late, eat junk food. All this is doing this, syndrome PCOS. And then you keep fighting with it the whole life. So achievable goals. If you ask somebody who's already, 90 kgs, that you have to drop down your weight till 50 kgs, that's pretty impossible even to hear. Give them short goals. 5% reduction in weight, 10% reduction in weight. It yields significant clinical improvements, remember that. Consider successful weight reduction in 6 months amount of time. And ask them to take a calorie deficit of, let's say, about just 30%. Just reduce your calories by 500 a day. And that will, coming down to 1200 to 1500 kilocalories, but just eat 1500 kilocalories or just 1200 kilocalories per day. And you will see how slowly things start improvising. Exercise is very important. Muscle straining exercise, like I tell you, adult PCOS women, a minimum of 150 minutes per week of moderate intensity exercises. Moderate, that means cycling, brisk walk, these are moderate. And in vigorous intensity, that means maybe swimming or jogging, running, these are all intense, vigorous intensities. So 75 minutes per week. Or a combination of both. Along with that, including muscle strengthening activities on 2 non-consecutive days of the week. At least 2 days a week, you have to strengthen your muscles. So muscle strengthening activities. In adolescents, at least 60 minutes of moderate to vigorous intensity physical activity. Just imagine, even adolescents are now included. And muscle strengthening at least 3 times per week. And behavioral strategies, so psychosocial strategies, that means you should not give up, okay? It should become a lifestyle change for you, okay? You're not doing it as part of, okay, fine, when I'll reach this goal, I'll just leave it. No, eating healthy becomes a part of your life. So how do you do that? You have to set a goal, you have to monitor yourself, you have to give a stimulus to yourself, you have to be more assertive, more disciplined, and obviously you have to reinforce these things again and again and again. So then, after that comes the pharmacological part. How will you regularize the menses? So if the patient, it all depends what is the problem with which the patient has come to you. Not every time a patient is going to come to you for just infertility. Sometimes patients really do come to you for menstrual regularity, okay? And in that case, you have to tell them, especially if they are just married and they are coming to you that, my periods have always been irregular. Now more so, I'm having more problem because now I'm in, a different house with my in-laws, and they have more erratic schedule of, visiting shrines and everything. And I don't know when my periods are going to come. So it's very difficult for me to, and I don't want to have a baby right now. So I don't want to get caught in between because I do not know when the period is. So I do not know when my ovulation is. So I don't want to accidentally fall. I don't want to accidentally get pregnant, and because of that, I just give me something so that my periods become all right. This is an ideal candidate for giving you OCPs. Ideal candidate. But if a patient comes to you with, I don't know when I'm going to have my periods, and I do not know how to, what is the fertility period. In that case, you have to counsel her before you give her OCPs, or if at all you do give OCPs, because till the time she is on these drugs to regularize her periods, she will not be able to conceive. So you should tell them accordingly. Now, why I have included so many figures is not just to show certain OCPs. I'm going to ask you these questions now. So what they're saying is that COCPs are the first line of treatment for irregular periods. Remember, for irregular periods. So COCPs with 20 to 30 micrograms of ethinyl estradiol or equivalent should be used, nothing more than that. So you have overall G, which has higher level of ethyl estradiol, but mostly all of them, any OCPs that you might be thinking of, usually have 20 to 30 or 35 at the max microgram of ethyl estradiol. And COCPs with anti-androgens like drospirenone, they can be considered on women with hirsutism. And the other non-androgenic progesterones are drospirenone, desogestrel, gestodine. Okay. Now, I'm going to get back to this. COCPs with cyproterone acetate should not be considered as a first line in PCOS because they have adverse effects because of venous thromboembolism. If you do see over here, I've kept 3 OC pills which were highly used before. Over here, I've kept them. Why? Because I want to tell you that you have more level of ethyl estradiol in these pills, and they were the ones which are not used now because of the effect of venous thromboembolic episodes. So earlier on, we used to give a lot of crimson, if you remember. Diane was given a lot because that was a newly launched cyproterone acetate molecule, and was given to those females who used to come with this menstrual irregularity with hirsutism and all, and they were doing fine with it. But now we discourage the use of these, crimson and diane because of basically the episodes of thromboembolism. And this, combination was made with a little more of, ethyl estradiol, just because it supplements or complements the effects of cyproterone acetate at that level. Okay, so now we have those non-androgenic progesterones. So can you guys enlist a few OCPs, brand names, with desogestrel as the progesterone component? You can write down in the chat box, you can unmute and speak. Desogestrel as the progesterone component in which OCPs? You've been prescribing it from quite some time, so I need this answer from you. Then I'll show you my next slide. I'll just see your answers and then I'll show you my next slide. So desogestrel as the progesterogenic component in OCPs, which all are there? Usually the period of OC pills is given between 3 to 6 months. Never give more than that. Or if you do have to give, you give a gap of, at least 2 to 3 months. Tell them to use, if they are married, if you don't want, if contraception is the main reason, then you have to explain it then. If it's an early, if usually a teenage girl comes to you, someday she's going to get married sooner than later. So in that case, you'll have to explain her that if she's going to have regular periods, she's going to have regular periods on this medicine. Most of them say no for OCPs alone. So what my method of counseling is that I don't want you to have regular periods on hormonal pills. I want you to have it yourself. So train yourself in terms of weight reduction is concerned, or eating right is concerned, or living right is concerned, timetable is concerned, exercise is concerned. If you do not get okay with that, then we'll think about OCPs. And that also I'll give for only 3 months or 6 months at the max. Again, you'll be back to. So if she's having such difficulty with menstrual irregularity that it's causing her psychological impact, only then give OCPs. Otherwise, there is no sense in giving for years together. And usually when you give this kind of counseling, they understand that more important is weight reduction, lifestyle change, lifestyle modification, than as compared to these taking pills. So nobody has answered. Okay, come on. Desogestrel as the main component. Okay, gestodine as the main progesterone component. Can anybody tell me? Yes, finally I got an answer. Femilon, Novilon, these were all desogestrel components, guys. You should know this, because when you do write down, like I said, after being PG, you are going to be SRs. SRs, write down all these brand names. You should know these OCPs. And mind you, in your table, Viva, these are the kind of questions that are asked to you. Desogestrel component OCP. How will you describe? How will you write down? Novilon, Femilon, yes. Yasmin, yes, correct. Okay, and okay, let's now shift to gestodine. Has anybody heard about gestodine as a progesterogenic component? Menace was sometimes used, sometimes early with gestodine, but gestodine is not that popular. Drospirenone. I will not hear anybody say I don't know about drospirenone. It's very famous. Drospirenone as a progesterogenic component in which OCPs? I think any OCP that you do remember, we'll be having drospirenone. Sorry, desogestrel was another famous one, and now drospirenone is a very, very famous component. So Dronis, yes, Dronis has this. Yes, correct. Absolutely, Dronis is one. There are many. There are many. What more? So welcome to my next slide, in which I've tried to explain all these different components. So you can see, your Yasmin has your, over here we've got drospirenone, you've got desogestrel and Femelon, in Novolon, okay, gestodine is there in Femovan and Minase, see over here, Minase. And in the, where is the drospirenone gone? Yeah, drospirenone in all these. As you can see, Dronis has drospirenone, Dronis 20, Dronis 30. Then you have Yamini, Yasmin, these all have drospirenone. And then you come to desogestrel. So you have Novolon, Femelon, and Intimacy. Intimacy plus 2, Intimacy plus 3, they have desogestrel. So desogestrel is very old. Femelon, Novolon, they had desogestrel, and even now Intimacy plus has desogestrel. And drospirenone is there in Dronis, Yasmin, Yamini. Okay, so you should know all these. Now we are at the fag end of our discussion, guys. I'm just going to conclude it with the insulin sensitizing agents. So here comes metformin. Now metformin is actually it's a wonder drug. Okay, given from the dose of 500 to as high as 2 grams a day. You can divide it into different, 500, 1500. You can give it in any permutation and combination in which the body starts showing its results. So treatment should be given for a period of minimum 3 to 6 months. That is also true with metformin. That's also true for OCPs. It's also true for Inositol, which we're going to be discussing later. It's got a few side effects like nausea, bloating, GI discomfort, but metformin otherwise does excellent for patients who are having this insulin resistance, because it's an insulin sensitizer. That's the mode of action. And metformin, the brand names are Glycomet, Metform, many. Okay. Then comes another agent, Inositol. Questions have been asked on Inositol, D-Chiro-Inositol, Myo-Inositol. What is it? How does it act? Whether it helps or not? And, the different permutation combinations available in the market and how much dose do they have. So I've included this as well. Myo-Inositol is a nutrient which belongs to the vitamin B complex, and it's being studied in the last 1 decade. And it's a mediator, nothing of insulin action actually. And evidence has shown that Myo-Inositol, it might improvise the hormonal profile. It might decrease hyperandrogenism. It decreases the oxidative abnormalities. And at the same time, the metabolic factors in the patients with PCOS, probably by the amelioration of insulin resistance in these patients. So somehow decreases the insulin resistance is what our main theory is. Now, the various theories that shown favorable results if the inositol combination, Myo-Inositol, is given in a dose of 4 grams per day. And mind you, most of the, these medicines in the market, they usually have 1 gram or 550 grams of, Myo-Inositol in them. And they have shown favorable results in terms of improvement in metabolic and endocrine and reproductive functions. So inositol, especially Myo-Inositol, can be given in PCOS women with BMI more than 25 or 23 in Indian scenario. And those who are having this incidence of persistent anovulation are ones who are poor ovulation induction, poor performance with ovulation induction drugs. And then apart from, of course, Myo-Inositol, then you finally go on to the most important thing. Guys, this to discuss about the anovulation and ovulation drugs. It's thoroughly covered already in my infertility package. Please, those of you who want to see those, my lectures are there. Some of them are there on the YouTube as well. The different protocols of ovulation induction, they've been thoroughly covered in my infertility package. It's all my lectures are there. Like I said, some of them are there on the YouTube as well. So it's beyond the scope of discussing over here. Okay, ovulation induction protocol. But you should just know that if you're talking about PCOS, I cannot just skip this part. So letrozole actually is the first line of ovulation induction drug. Why? Because it's supposed to be, as compared to clomiphene citrate, it causes monoovulation. So less chance of OHSS syndrome. At the same time, it's got a very favorable profile on the endometrium, which clomiphene citrate does not have. So what is the dose? 2.5 to 5 milligram for 5 days, starting from day 3 of the menstrual cycle till day 7 of the menstrual cycle. The other ones are gonadotropins, which can be added if there is an adequate response from letrozole and clomiphene citrate. Usually, patients with PCOS, they're pretty good in responding to the ovulation induction protocol, especially that with letrozole. And you might need to add a few gonadotropins rather than starting. Usually, you need gonadotropins for IVF patients, in which a good cohort of developing follicles is needed together for oocyte retrieval. And then there's one thing towards the end which I'd like to tell you about, which is laparoscopic ovarian drilling, which I spoke right at the beginning because of such thick wall of the ovary, the pearly white wall. So what you do is you do an Armour's rule. You give 4 punctures in each ovary with 40 watts of current for 4 seconds, going till a depth of around 4 millimeters in each ovary. So you hold the ovary and you do this drilling. And what are the indications? Now this can be a question in the exam. A 5-mark short note on laparoscopic ovarian drilling for PCOS patients. So you will tell me what are the candidates for laparoscopic ovarian drilling, how do you do the drilling, and what are the complications of this laparoscopic ovarian drilling. That this is more invasive. Obviously, you'll have to give a general anesthesia to patient. You have to put the patient in the OT. You have to do all pre-op checkup for the patient. So it's disadvantages. And who all are the candidates for that? The patients who are having no ovulation or conception after multiple ovulation induction cycles. When the laparoscopy is being already performed for some other reason, you might as well go ahead and do laparoscopic ovarian drilling. When the patient is unable to follow up for regular ultrasound scans while on gonadotropin injections and previous history of OHSS in this kind of patient, you will go ahead and do the laparoscopic ovarian drilling before you take up the patient for further tests. And then, of course, you have your in vitro fertilization, which is the last resort to any patient who is not able to conceive, with so many dietary and modifications, along with trying to reduce insulin resistance, trying to do the ovulatory induction protocols. You have the last resort as IVF. And towards the end, I conclude my lecture, guys, with these few questions that I'd like to show you, which have been asked in the examination. So I'm really sorry, but today's lecture was, despite the fact that I thought it's going to end up very fast, it's pretty. So these are the questions. See, pathophysiology has been asked, health consequences has been asked. Okay, ovulation induction has been asked. Then steroidogenesis on ovary, again, the same way of asking a different kind of questions asked. I told you about inositols that they have been asked. What are inositols? The role, physical roles, and utility in ISO. I will be doing that, Devraj. I'll just show you the initial slides first. You can go ahead and see these slides. I'll just put up a slideshow for you all, guys. Okay, and you can see it. In the meanwhile, I'll just take a short break.